Hey everyone, this is Daily Dose of Medicine. In this video, we will talk about community-acquired pneumonia. Specifically, what is community-acquired pneumonia, symptoms, risk factors, diagnosis, treatment, and vaccination. What is community-acquired pneumonia? Community-acquired pneumonia in adults is an infection of the lung parenchyma acquired outside of hospital or healthcare setting. In the US, it accounts for over 4.5 million outpatient and emergency room visits annually, corresponding to approximately 0.4% of all encounters. It's the second most common cause of hospitalization and the most common cause of infectious cause of death. The most commonly identified causes of community-acquired pneumonia can be grouped into three different categories. We have typical bacteria like streptococcus pneumonia, which is the most common bacterial cause, Haemophilus influenza, Moraxella, and many more. We have atypical bacteria. Atypical refers to the intrinsic resistance to these organisms to beta-lactams and their inability to be visualized on gram stain or cultured using traditional techniques. We have Legionella, Mycoplasma, Chlamydia, and Chlamydia stachy and pneumonia specifically, and Coxiella. We also have respiratory viruses like influenza A and B, SARS-CoV-2, other coronaviruses, rhinoviruses, parainfluenza, adenoviruses, and respiratory syncytial virus, human metapneumovirus, human Boca viruses. Which symptoms you will see with pneumonia? It typically presents with symptoms such as cough, fever, dyspnea, and pleuritic chest pain. Other symptoms may include fatigue, myalgias, and gastrointestinal symptoms like nausea and vomiting. And in physical examination, we can see tachypnea, tachycardia, and crackles or waves on lung auscultation. The risk factors for community-acquired pneumonia: age, older adults, particularly those aged over 65. Gender, men have a higher risk. Contact with children, regular contacts with children can increase the risk. Chronic respiratory diseases like COPD, asthma, chronic bronchitis are significant risk factors. Previous respiratory infections like history of recent respiratory tract infections or previous pneumonia episodes increases the risk. Comorbidities, chronic conditions like diabetes, chronic liver disease, chronic heart disease, and renal dysfunction are associated with a higher risk. Immunosuppressive drugs, including oral steroids, increase susceptibility to community-acquired pneumonia. Poor functional status and cognitive impairments are significant risk factors, particularly in the elderly. Sudden temperature changes, exposure to sudden changes in temperature at work also increases the risk. Household conditions, living in households with more than 10 people or having contact with pets are additional risk. Some medications like gastric acid suppressive drugs have been linked to increased risk for pneumonia. Inhalation therapy, particularly those containing steroids and using plastic peer spacers. For diagnosis, we generally require demonstration of an infiltrate on chest imaging in a patient with a clinically compatible syndrome, fever, dyspnea, cough, and sputum production, and we do chest imaging, and then we diagnose it, community-acquired pneumonia. For most patients with suspected community-acquired pneumonia, we obtain posterior, anterior, and lateral chest radiographs. Radiographic findings consistent with the diagnosis of community-acquired pneumonia include lobar consolidations, interstitial infiltrates, and/or cavitations. For selected patients, we might use CT of the chest in case we have negative chest radiograph. These patients include immunocompromised patients who may not mount strong inflammatory responses and thus have negative chest radiographs, as well as patients with known exposure to epidemic pathogens like Legionella. Because there is no direct evidence to suggest that CT scanning improves outcomes for most patients, and the cost is high, we do not routinely obtain CAT scans when evaluating patients for community-acquired pneumonia. And laboratory findings we see while diagnosing community-acquired pneumonia are leukocytosis, high white blood cell count, or low white blood cell count, leukopenia, elevated inflammatory markers, and hypoxemia, low oxygen levels in the severe cases. For patients with a working diagnosis of community-acquired pneumonia, the next steps for us defining the severity of illness and determining most appropriate site of care. Determining the severity of illness based on clinical judgment, and it can be supplemented by use of severity scores. We have two different scoring systems. One is Pneumonia Severity Index, and the other one is Curve 65. Here we have Curve 65. All of these factors are 1 point, and if patient has more than two or more than 2 points, we consider inpatient treatment. And here we have Pneumonia Severity Index. Each of these factors add certain points, like mental confusion is plus 20, and if patient has more than 70, we consider inpatient treatment. And here you can see mortality rates with every point. Patients with moderate community-acquired pneumonia admitted to the general medicine ward. For most patients with this situation, we obtain the following: blood cultures, sputum, gram stain and culture, urinary antigen testing for streptococcus pneumonia, testing for Legionella, and SARS-CoV-2 for coronavirus. Let's talk about the treatment for most patients aged less than 65 who are otherwise healthy and have not recently used antibiotics. We usually go with oral amoxicillin plus a macrolide like azithromycin or clarithromycin or doxycycline. Generally, we prefer to use a macrolide over doxycycline. So we go with amoxicillin plus a macrolide. But for American Thoracic Society, Infectious Diseases Society of America, these two establishments, they recommend monotherapy with amoxicillin as first line and monotherapy with either doxycycline or macrolide as alternatives. For patients who have major comorbidities like chronic heart, lung, kidney, or liver disease, diabetes, alcohol dependence, or immunosuppression, who are smokers or have used antibiotics within the past 3 months, amoxicillin clonates, and plus either a macrolide or doxycycline. Alternatively, we might use respiratory fluoroquinolone like levofloxacin or moxifloxacin as a monotherapy. While we are treating patients inpatient, for patients with community-acquired pneumonia admitted to general medical ward, empiric antibiotic regimens are designed to treat staph aureus, gram-negative enteric bacilli, in addition to typical pathogens and atypical pathogens. So we generally start antibiotic therapy as soon as we are confident with the diagnosis, and ideally within 4 hours of presentation. Delays in appropriate antibiotic treatment that exceed 4 hours have been associated with increased mortality. And if we don't have any suspicion for MRSA or Pseudomonas bacteria, we generally use one of the two regimens: combination therapy with a beta-lactam antibiotics like augmentin plus a macrolide, or monotherapy with respiratory fluoroquinolone like moxifloxacin. For patients with known colonization or prior infection with Pseudomonas, recent hospitalization with IV antibiotic use, or strong suspicion for Pseudomonal infection, we typically use combination therapy with both an anti-Pseudomonal beta-lactam. Here you can see examples of that, plus an anti-Pseudomonal fluoroquinolone like ciprofloxacin or levofloxacin. For patients with known colonization or prior infection with MRSA or other strong suspicion for MRSA infection, we can add agent with anti-MRSA activity like vancomycin or linezolid. In patients we are treating in intensive care unit, our approach to antibiotic selection is similar to that used for patients admitted to general medical ward. However, because of the severity of illness of this population, we do not use monotherapy. In addition, we start antibiotic therapy within 1 hour of presentation for patients who are critically ill. For most patients without suspicion for Mercer and Pseudomonas, we treat with beta-lactam. Here we can see some of the examples here, plus a macrolide, azithromycin or clarithromycin, or beta-lactam plus respiratory fluoroquinolone like levofloxacin or moxifloxacin. For all patients, we treat until the patient has been febrile and clinically stable for at least 48 hours and for a minimum of 5 days. Patients with mild infection generally require 5 to 7 days of therapy. Patients with severe infection or chronic comorbidities generally require 7 to 10 days of therapy. Vaccination remains critical components of community-acquired pneumonia prevention. The CDC recommends pneumococcal vaccination for adults, all adults aged 65 or older, and for those aged 19 to 64 with certain underlying conditions. The 20-valent pneumococcal conjugate vaccine or the 15-valent pneumococcal conjugate vaccine, followed by 23-valent pneumococcal polysaccharide vaccine 1 year later are recommended. Additionally, annual influenza vaccination, COVID-19 vaccination are advised for all adults to reduce the incidence of viral pneumonia and its complications. Thank you so much for watching. You can find the studies I've used to gather this information from the links down below. Don't forget to join our channel membership. I'll see you in the next one.